Hello, everyone. You can hear me okay, yeah?
Yes, clearly, doctor.
Yeah, perfect. So my name is Dr. Isla Robertson. As she said, I'm an obstetrics and gynecology doctor and an MD student at the University of Southampton. I'm going to present so many thanks for the opportunity to present today and for the kind nomination from Professor James Batchelor. So I'm going to present some of my work towards my MD thesis, looking at using digital health technologies to improve efficiency in reproductive medicine. And this has been primarily supervised by Professor Ying Chung. So looking at digital health technology to improve efficiency in reproductive medicine, I've defined efficiency in its broadest sense, with efficient care being improved quality or equal quality care with reduced treatment burden for patients. So reduced kind of stress and intensity of treatment while they're having their IVF treatment. And I've focused on understanding and improving the quality of patient experience during their reproductive medical care using digital tools. So I've just summarized an IVF cycle in the middle here for people who may not be familiar with it. So it all happens during quite an intense period lasting around 1 month. And patients take injections to hyperstimulate their ovaries so they produce more eggs than normal, and have multiple ultrasound scans tracking the growth of the follicles that contain the eggs. They then have an egg retrieval procedure. The eggs are then mixed with sperm in the laboratory to create embryos and then grown. And that's either done by IVF, where they're just left in a dish, or ICSI, where one sperm is injected into each of the eggs that we've collected. Then they're grown to around about day 5 and the best embryo transferred back to the patient. So kind of looking widely around this cycle, thinking how we can use digital technology. First of all, I've looked at how we can streamline the scans that patients have during the ovarian hyperstimulation phase. And so used machine learning and a 10-year database of scans from our centre to try and work out which scans are predictive of when the patient will need to have their eggs collected and which scans are less useful. And this work has been particularly useful during COVID times, when we've been trying to reduce the number of patient visits that are necessary for them to kind of come to have scans during their cycle. And probably even without knowing much about it, if you look at this graph, which is one patient's scans at various days during the cycle, you can probably see that the early scans on day 2 and day 5 are much less predictive of when the eggs are going to be ready to collect, and that you could possibly miss out them having to come for those scans, which are quite unpleasant for the patients. We've then looked at using data from our database. Can we predict who will get a good quality embryo? And produced a web app tool using that predictive model that clinicians can use to guide their expectation setting conversations with patients. But today I'm going to talk mostly about my work looking at support for patients with involving digital technology. So first of all, a systematic review of what digital support tools are available currently, and is there evidence that they work? And then looking in particular at one particular tool, Medimo, that's been developed in the centre that I work in, and looking at emotional data that patients have entered into this smartphone app during their IVF cycle. So we've got a 3-year database where the patients have been using the app and using this data to try and evaluate, is IVF more stressful during COVID times? And do emotions differ between the different types of treatment cycles we do? And can we use the emotions that patients enter during the cycle to try and predict whether they're likely to drop out from treatment? So dropout is a big problem in IVF care. and high rates of dropout are seen after a failed first cycle of treatment, even in countries and health systems where there's generous funding for IVF cycles. So even in countries like Israel or Denmark, where multiple cycles are funded by the public health system, there's still a high rate of patients dropping out from treatment because they find it such a stressful and difficult process to go through. So first of all, I'm just going to talk about my systematic review. And so if you type IVF or kind of similar keywords into an app store, I've just put a screenshot of the kind of initial types of digital tools and apps that will be presented to you. And it's very common for patients to want to use an app, but it's quite difficult for them to work out, is this app a quality one? Is the information within it likely to be accurate? Are the more expensive apps the most useful? Is it worth paying money for an app to use alongside my IVF cycle? Is it going to integrate with the clinic that I'm having treatment with? Can I get my test results, find out information about my embryos? And who's kind of made and is running this app? Is it a company? Is it a particular clinic? Is fluffy, cute apps a useful source of medical information about IVF? There is some research in this area already. So Zwingerman et al. Reviewed health apps generally in the context of women's health and found that they didn't appropriately address the needs of patients struggling with infertility, and that in general, apps were of low quality with significant inaccuracies in content. So to try and find out more information about apps that are designed to support patients alongside IVF, I've done a systematic review. So here's the Prisma flowchart for that. And so this involved systematically searching the Google Play Store, Apple App Store, and the Your Health App Finder database, and then relevant electronic literature databases, so Embase, Medline, CINAHL, and PsycInfo, which include more psychology-based studies. And if you're not familiar with the Orca-based Your Health App Finder, this is a app database that gives patients some information about the quality of the apps that come up in the search. So the app is rated according to what level it is. So 0 is a kind of well-being general app, and level 4 is apps with kind of specific medical information about particular conditions and that would be expected to be regulated to some extent. And it also gives a percentage score about the app quality. And if you press on that, some further information about what data is collected, how it's used, and that's combined to give a percentage. So I searched all 3 of those databases and identified 59 apps for further assessment, apps and web tools. Had to exclude some of them because they weren't available in English, but appeared to meet the inclusion and exclusion criteria other than that, such as the Magatama app from IVF Japan, but eventually ended up with 43 tools to kind of analyze further in the study. And this just summarizes some of the salient features of the apps that we identified. So most of them were free. The most common included features were information, including videos for patients, so particularly things like how to take their IVF medication. Calendars were a very frequent feature, and they varied between calendars that were set up by the clinic, kind of populated with the medication the patients needed to take, some that integrated with patients' existing calendars like Google Calendar, and some where the patients had to manually enter all their own information into the app calendar. And there's quite a busy chart, but just summarizing again the salient features, and I'll just pick out a few points. So a number of them included a 2-way messaging feature, so for the patient to directly message the clinic and back. In one app, that was optional for the clinic, so they could choose to only be able to message the patient but not be able to message back, which I thought was quite interesting. Much less of them included a notification feature where the app reminded the patient to take their medication when it was due, and even less the tool was kind of directly integrated with the electronic health record that was being used in the fertility clinic. Then went on to review user reviews that have been entered into the App Store, because they're a valuable source of insight that can be easily extracted, and I extracted them using the App Follow tool. It was quite interesting that even though some of these apps had huge numbers of users, so for one in particular, over 35,000 patients had used it during their IVF cycle, there were very few kind of ratings. There was lots of numeric only ratings, but very few with written comments. I performed thematic analysis on the reviews that were available. In general, in terms of positive comments, patients found that the content was good. Some of them had found that their apps had reduced the stress of their treatment. There was comments that patients liked apps that both partners in a couple could use together. And the messaging tools, it was commented that patients appreciated that. In terms of negative comments, they were mostly related to the user experience within the app, so login and password problems. I think because some of these apps contain medical data, there's a need to kind of get through lots of security aspects and needing to repeatedly enter login information. And some reviews stated that that made the app not kind of functional for use, because they were having to log in so often when they wanted to quickly look at something. And there was a general theme that patients were intolerant of apps being clunky and with a poor user experience compared to other apps that they are used to using in their general life. So here's just kind of a summary of the tools that were identified in the search. And I've highlighted ones where I could find any kind of research related to the tool. So almost for the web-based programs, there was quite a few RCT-based studies, and I'll go on to talk about that. For the apps, there were only really conference abstracts related to them. So for the research evidence that was available, I went on to do a meta-analysis. So this identified 9 studies. So one abstract that presented an RCT related to an app called Fertistrong, but 8 of them were web-based tools that had been subjected to RCT design studies with users of the tool compared to waiting lists or control non-users. The tools contained a variety of features, mostly kind of digital versions of existing face-to-face support that's available for patients having IVF. So things like CBT, cognitive behavioral therapy, translated into a web-based version. There's quite high dropout rates from a number of the studies, kind of up to 37% in some of the studies. It was interesting that a number of them did include both partners in the couple, whereas a lot of IVF research is exclusively focused on the female partner. Some of them, kind of roughly half, reported usage behavior, which is quite important in a digital tool study. And there was a variety of outcomes scales used for psychological outcomes, including some fertility specific and some general tools. And 4 of them reported pregnancy rates between users and non-users. So just kind of very briefly present the evidence that it was possible to collate. So looking at the fertility problem inventory, which is a fertility specific psychological outcome score, there was a slight trend, but no significant difference between users of digital tools versus non-users. And similarly with depression, no significant effect found on depression markers, and the same with anxiety, no significant impact. But when we collated the data on pregnancy rates, we did see a small significant increase in pregnancy rates among users of the tools compared to controls. Only 4 of the studies had reported pregnancy rates, so it's possible there's some reporting bias affecting this outcome, but it does fit with other studies that have evaluated non-digital psychological support tools for fertility patients. So there's 2 systematic reviews which have found no significant effect on psychological outcome measures, but a small improvement in pregnancy rates for patients who've used non-digital psychological support. So now I'm going to move on to the next part of my talk, and this is focusing on one particular app, Medimo. So this is just a slide introducing Medimo. It has a medication timeline arm, so the clinic loads all the medications that the patient needs to take during their treatment cycle into the app via a portal and the date and time that they're supposed to take them. And it then sends the patient a notification when the medication is due, and the patient swipes the app to record their medication is being taken. And if they don't, then send kind of reminder notifications to try and reduce medication error during IVF. It also has an emotion arm, which prompts patients to perform daily mood monitoring and provides coping techniques and psychological support tools. So I'm going to particularly focus on the database of users who've entered emotional data into this daily record keeping. So they're asked to rate their score for these questions, and then that's recorded within the app. But it also has coping support tools, so positive coping reappraisal intervention and suggestions about distraction and psychological techniques for patients to use when they're feeling stressed during their cycle. So just kind of a bit of to clarify the emotional data we're collecting. So this is based on validated tools that have been used in questionnaire-based studies in IVF cycles. And it asks questions in 3 domains. So threat, which includes worry, tension, nervousness, and anxiety. Harm questions, which includes disappointedness. And challenge questions. So is the patient feeling confident, encouraged, hopeful, or positive? Every day the patient's prompted by the app to fill in 8 questions. They don't necessarily report on every day. And on days where they do report, only 2 questions from each domain will be asked within the app. They're also asked a Boolean question about, are they experiencing any vaginal spotting, bleeding, because that's known to be related to psychological emotions during IVF cycles, because it's a kind of signifier that the cycle may not be going so well, and about if they feel they're able to cope with the stress that they're currently experiencing. So this is a heat map which contains the correlation between the answers to the various questions in the database. So you can see from the diagonal from the top left to the bottom right that there's a very strong correlation in answers to questions in the same category, which is what we'd expect with use of this tool. So if you're feeling anxious, you're very likely to be feeling tense as well, and the kind of answers within the database reflect that. Overall, the answers to the threat and harm questions are correlated, as you might expect, and that challenge questions, so how optimistic the patient's feeling, is negatively correlated with how stressed they're feeling during the cycle. This displays patients' usage of the app, the emotional tracking part of the app during IVF. So around 96% of patients downloaded and used the app to some extent, but the emotional tracking engagement was less, as we commonly see in psychological studies, somewhere between 50 55% of patients entered some emotional data, and they tend to enter it starting at the time when their stimulation starts, at the start of the cycle that I described, and then there's a gradual drop off during the stimulation phase before egg collection, which happens on day 0 on this graph. And then there's a kind of cohort that continue to use it during the 2-week wait cycle, part of the cycle, before they find out whether they're pregnant or not. And then once they know whether they're pregnant or not, engagement with the app significantly drops off, as you might expect. Here we've correlated the mean mood scores entered by patients into the Medimo app to whether they had a live birth or not in the different question categories. So these are quite interesting results. So first of all, looking at challenge. So I'll just kind of go through it, that on the x-axis is the day of the cycle relative to egg collection day, which happens on cycle day 0. So in the around 10 days before that, 10, 12 days, they're taking injections to get eggs ready to collect. Then they're collected on day 0, an embryo is transferred back, and they wait for around 14 days to find out whether they're pregnant or not. And in general, the mean mood scores shown on the y-axis, and in the red and the blue are whether the cycle ended up in birth of a baby or not. So those that did have a baby in blue and those that didn't in red. So in general, all patients, when they start an IVF cycle, are reasonably confident, encouraged, hopeful and positive. Their rating scores kind of 1.7-ish on a 0 to 3 scale, which is kind of relatively hopeful and positive. That continues during the first part of the cycle. They have their embryo transferred back, and then there's a big spike in hopefulness and encouragement when they find out that they're pregnant, for the ones who go on to have a live birth. And you can see earlier in the cycle, there's a spike in hopefulness and encouragement when they probably have a good number of eggs collected in that group. If we contrast that to the tension, so this is the kind of anxiety scores, and we see these gradually building across the cycle, particularly in the 2-week wait phase. So after day 0, when they've had the embryo, they've had eggs collected and then an embryo transfer back, then they're becoming tense, worried and anxious, not sure whether the cycle's going to work or not, and they're going to get pregnant. And then after day roughly 14, when they take the pregnancy test, we see a big drop off in tension, because whatever's going to happen has happened. There's no point worrying about it anymore. So in both groups, those emotions drop away. If we move on to the harm scores, so patients are not feeling harm, particularly at the start of the cycle, but then a big jump in harm for the patients who don't go on to have a baby happens before the time they find out they're pregnant. So perhaps they're getting some negative feedback, they're starting to have some vaginal bleeding, or they think this is just not going to work, and a big spike in sadness, discouragement and disappointment when they find out they're not pregnant. And if you look at the stress graph on the right, so remember, this is patients entering whether they feel able to cope with the stress that they're experiencing, and a big spike in patients feeling that they're not able to cope with the stress that they're under, for those who haven't become pregnant during the IVF. So I think these graphs are showing that Medimo is picking up at the kind of true emotions during an IVF cycle, and that we should never underestimate how emotionally difficult these cycles are for patients, and that these patients who are feeling unable to cope with their stress need lots of support and help from the clinic to cope with the emotions that they're experiencing. So in terms of research questions using this database, we wanted to look at, is the experience different since the global COVID-19 pandemic started? Is the emotional experience different between different types of cycles? And can we identify an emotional signature that is associated with an increased risk of the patient dropping out from treatment? And if so, can we build this into the tool so that we could identify patients during the cycle and help them to make them more likely to return for more treatment and to fulfill their parenthood goals. So first of all, the psychological impact of COVID. So COVID was declared a pandemic, kind of worldwide pandemic, exactly a year ago today, and it necessitated shutdown of UK IVF centres. So between March and May, mid-May, June 2020. And here I'm presenting the Medimo mean mood scores by mood category by month of entry in year 2020 between January and September. And you can see that there's a big spike in the purple, green and red, so threat, harm and stress emotions seen around that time, and a drop in the blue, so the challenge emotions, patients feeling less optimistic. And the big spike in stress is patients feeling that they're not able to cope with the stress they're experiencing at that time. And 40% of patients who were entering emotional data during that period felt unable to cope with the stress they were currently experiencing. We've looked at pre-COVID, so before February 2020, compared to after we reopened at the end of May 2020. And interestingly, there's been a shift in challenge emotions, a significant shift that patients are feeling less confident and hopeful since restarting than they were before COVID started. But there's been no significant change in how harmed or threatened or stressed they feel when they're actually going through the cycle. We've just started looking at the emotional experience between different types of cycles. So I've talked about the main IVF treatment, but if that doesn't work, a patient can then come and have a spare embryo that was created during the IVF cycle replaced in a frozen embryo cycle. And so we've compared those different types of treatment cycles and the emotions patients entered into the app, and also looked at IUI cycles, which are less intense cycles. Patients take some stimulation medication, but then simply have sperm injected into the womb, so they don't have to go through the theatre procedure of having eggs collected and embryos transferred back. Interestingly, patients feel more optimism in IUI or frozen embryo cycles, but there was a significant increase in harm levels associated with the frozen cycles. So when patients already have an embryo in the freezer and then have a cycle where they have the lining of the womb prepared and then that embryo transferred back, they feel higher rates of harm emotions during that cycle. And it's interesting to kind of reflect on why that might be. Perhaps they've not coped with the grief of their failed initial treatment cycle yet, or the expectations are higher because the embryo's already been created and been of good enough quality to freeze. So there's then more pressure on the patient. Is it going to implant or not when you transfer it back? But it's kind of interesting initial data here. So if the last part of the work I'm going to talk about is our work that I've been doing in conjunction with a computer scientist, Dr. Francis Schmiel, and we've been looking at trying to use machine learning to predict who is likely to return for further treatment or not. So in the initial part of this analysis, we've clustered patients by their emotional responses that they entered into the app. And to start this work, we created a cohort of relevant patients. So those who didn't have a live birth during their first complete cycle, so any fresh or frozen embryo transfers from one egg collection. So we want to know if the first set of treatment doesn't work, do they come back for more treatment or not? Or do they decide that was really horrible and stressful, I don't want to come back and have any more treatment? So we created this cohort of patients, and they had to have reported at least once emotional data during the treatment cycle, so we could use that for prediction. We then did k-means clustering analysis and selected the optimal number of clusters using the silhouette method. And I'll present embedded mean mood scores in 2D space using UMAP. And kind of this is the image of that. So each dot presented is a patient, and at the top left is their anxiety score, mean mood score during the cycle, confidence, and then stress on the bottom left. And then the bottom right panel shows the identified clusters of patients, and the silhouette method identified the optimal number of clusters of patients was 3. The clusters are not that well defined, but you can see in the 3 different colors there on the bottom right that there are 3 broad nodes of patients. Cluster 0, those that don't report any high mood scores in any of the categories. Cluster 1, those with the high challenge, kind of optimism, hopefulness scores. And cluster 2, those with the high mean harm scores. And we looked at the return rates of patients in each of these clusters and found that there were significant differences. So cluster 1, those with the high mean challenge scores, have a higher return rate than the other 2 clusters combined. And that kind of makes sense that those that are feeling positive and optimistic during their cycle are more likely to return for further treatment cycles. There were no significant differences observed between the return rates of cluster 2 and cluster 1. So we wanted to see, can we use the mood scores patients have entered into Medimo to predict whether they're likely to return for more treatment? As it's quite useful to know if patients will return for more treatment and possibly to target additional support to those patients who are less likely to return for treatment. So we did this using basic logistic regression and looked at predicting return within 1 year of their first treatment cycle, and used area under the receiver operating curve to evaluate predictive performance. We found that age and the number of eggs the patient had collected, which is strongly correlated with age, were the kind of predictive factors of whether they were likely to return. Their raw scores entered into Medimo in the anxious, confident, and stress domains weren't predictive, so the area under the curve was 0.44, but the cluster assignment was weakly predicted, so that model was only using the mood scores. The assignment only uses their mood scores, puts them into clusters, but once you do have the cluster assigned to the patient, then that is of some predictive value, but weak predictive. If you combine age and eggs, improve it slightly, age and cluster again, and age and eggs and cluster, you can predict with an area under the curve of 0.635. So we're still talking about weak predictions here, but this machine learning analysis is showing that the emotional cluster data does contain some additional information about whether a patient is likely to return for more treatment or not. And we've done some further analysis of that. So the area under the curve worked out on an out-of-fold sample who weren't involved in the building of the model, and then looked at sensitivity and specificity using Udon's J statistics. So lots of information there, so I won't go into that too much. But again, just showing that emotional data has something to add, is suggested by this analysis, but it is not hugely predictive. So ongoing work with this database. So we're looking at the return rate of patients for non-users of the app versus people who use the app but only the medication timeline part of it, versus people who use both parts of the app kind of as recommended and suggested. Is there a suggestion that patients may be benefiting from using Medimo? Although to analyse that fully, we need to do a randomised trial of users versus non-users. We're also looking into analysing scores by age. We know that age is highly predictive of prognosis in IVF, but this doesn't seem to be reflected in the emotional scores that patients enter during treatment. We're also looking at further analysis of this predictive information that emotional cluster encodes, SHAP analysis of our models to work out kind of more information about what it's using to make its predictions. But kind of immediately we've implemented some learning from this clinical work. So particularly those graphs that we showed in showing the big spikes in emotional harm scores in the 2-week wait part of the cycle when patients are waiting to find out if they're pregnant. So we've increased supportive calls to patients during this part of the cycle when traditionally they have less contact with clinic staff because there's no kind of intervention happening at that point in the cycle. And we've kind of reiterated to patients that counselling is always available to them during that time. So I'll just leave up the outline of my work that I've done so far towards my MD. So my systematic review looking at what tools are available for patients and what quality they are, and is there any evidence that they're useful for our IVF patients. A study looking at trying to streamline scan monitoring to make IVF less disruptive and horrible for patients, and also to make it safer during COVID times. Our work trying to predict who will get a good quality embryo, and then the main focus of the work looking at Medimo and emotional scores during IVF and how we can use that to try and help our patients. Put up my Twitter handle there, and I'd be interested to connect with anyone who has an interest in emotional data and digital tools or reproductive medicine in any way. And thank you again for the opportunity to talk.
Yes, thank you for sharing your work with us, Dr. Isla. So to all our participants, we're now open for questions. You may type them in the chat box, or you can raise your hand so we can we can call your name, then you can unmute your mic. For the first question, we have a question from Dr. Alvin. So he's asking, will use of the app require matching of patient with an OBGYN, or will general practitioner suffice?
So at the moment, it's only available for use in our centre. So it's designed for use alongside an IVF cycle. In the UK, that's kind of exclusively in tertiary fertility centres. The way the app is designed with the medication and emotional arms is deliberately so that it could be useful in many different types of treatment cycles, so entirely not IVF specific. So there's many different types of medical treatment where patients need to take a complex schedule of medication. So thinking about kind of diabetes or various cancer treatments or kind of rheumatology type condition, lots of different things where the treatment is also burdensome and stressful for them, and tracking their emotions and accessing specifically designed emotional coping techniques might be useful. So the way we've designed it is to try and make it open, so it could be programmed and used by any type of medical doctor, including general practitioners. But at the moment, it's only used kind of alongside our IVF cycle treatments, and so programmed by fertility specific doctors.
Right. Thank you, Dr. Isla. And then there's a follow-up question. Should the app be prescribed by an OB/GYN?
I think that's quite interesting, and an interesting question generally when thinking about digital tools and apps. I think it's not currently in kind of UK regulation, it's not a medical device, although it's quite, I think the boundary of what's a medical device or not related to digital tools and apps is quite interesting, because if something's telling you what medication you need to take and when you need to take it, it's very quite close to being a medical device, I would say. I think there's a legitimization of a medical doctor prescribing a digital tool, but that's certainly not, doesn't tend to be the UK workflow at the moment. And I think looking ahead, increased digital tool prescription, but probably alongside that, increased regulation of these digital tools is likely to increase uptake and use. So if something isn't prescribed and recommended by a doctor, that it's probably less likely that a patient's going to fully engage and use it. But if it is prescribed, then the doctor's taking responsibility for the accuracy, contents, and function of that app. And unless the doctor is kind of upkeeping the app and making sure it stays up to date and relevant, it's kind of difficult for them to take that responsibility. So kind of, if anyone else has got any thoughts that they want to pitch in on that, I'd say it's not prescribed at the moment for Medimo, but it's, I think, looking forward, that increased integration with electronic healthcare records and increased prescription is likely to be the way that digital tools in medicine evolve.
Thank you, Dr. Isla. So are there any more questions from our participants? Or anything you would like to share if you have come across applications like this?
Yes, Cha. Hi, Cha. This is Dr. Alvin. Hi, Dr. Ayla. Thank you for your presentation. I think we also have OB-GYNs in the call. But I'm not an OB myself. I'm a surgeon, and I wanted to ask um, if you're using it right now in the University of Southampton. So essentially, the patients are pre-selected, and they have a fertility specialist advising them on how to use the app and how to install it. And it's not really a self-installed, self-service app right now. Is that
Yeah,
correct?
yeah,
Uh-huh.
that's correct. So the patient downloads it themselves, but they it's a nursing consultation in which they get guidance about how to use it and check that they've installed it properly and made an account. And the nursing team upload all the medication that they need to take into the app. And if it's quite common to change a patient's medication regime during an IVF cycle, and that's one of the benefits of the app, that we can change it centrally via our portal and then send the patient a notification so that they know that the medication they need to take has changed. And that was one of the main drivers of developing the app, because we used to have to call the patients multiple times during the IVF cycle. It's difficult to get through to them because they're at work often. And then there's kind of lots of workflow problems with doing that. So the app has solved that aspect of it.
That's why I asked about the app being prescribed, because in fact, no patient will actually have the app unless there was a fertility specialist who, in quotation marks, prescribed it to them and instructed them how to use it properly. And because of that, the fertility specialist would have feedback almost near real time. And it's almost like remote patient monitoring. You're getting feedback from the patient, which adjust, revise, or maintain the current regimen, making it more refined and more and less tedious, I guess, because you don't need to do the usual call the patient, ask them about certain parameters.
Yeah, absolutely. It's got that benefit, and the ability to message the patient. It's useful as well.
Could you tell us? Yes. Could you tell us just briefly how long from conceptualization to the first patient? How long did it take the group to, from the time it was conceptualized as an idea to the time the app was being used by the first patient? Because usually that's a challenge right now.
Yeah, I think in the region of around a year.
A year, and that includes the ethical approvals that you have to go through.
It was developed in partnership with a psychologist from the University of Cardiff and a software company, has a Horizon Strategic Partners. And I think having that company involved sped up the process of, but it is a lengthy process, and making changes to the app in response to kind of using it and patient feedback and trying to kind of improve it to increase onboarding of patients and their user experience, it all does take a lot of time. So it's been in use since May 2017. I think we'd have expected to have been rolling it out a bit more widely, and there's been interest in that, but then we've been making improvements and things. So I think that is the problem with app development, that it does take time, and it's often, if you're trying to do it on a research basis, that it's difficult to keep up with apps that are just being put out there for use without that kind of evidence gathering phase.
Right. So I think you're doing that. You're doing the right thing. You're doing the data gathering right now, making sure that there's evidence before the app gets scaled out. Do you think it will work in the US and other English-speaking countries, or there's a lot of context that only works in the UK? Over.
No, I think any English-speaking country, it would work well. IVF prescriptions are not particularly variable, and you can change the possible drugs that are available within the app to when you upload it. So it is specifically designed to be multi-purpose, so not even completely IVF specific, but within IVF care, yeah, I think it's very widely applicable.
And in the future, where maybe it's already commercial, who do you think would be paying for it? The insurance company, the patient, or the doctor's practice?
Yeah, that's an interesting area, I think. And there's various models of apps for use alongside IVF and e-health portals integrated into it. Yeah. And there's one identified in my systematic review. The patient pays €15 a month to use that app. Sometimes there's a one-off charge of up to $99 to use the app, which seemed quite expensive to me. I think the model with our app would be that the clinic kind of buys a license to use it, and then it's included as part of the care package for the patient.
There's a question from Carlo Cordero. Would like to ask, how high is the accuracy of your machine learning model? Over.
Yeah, so I'm not sure if he's referring to the blastocyst prediction model that I talked about, that so the kind of web tool to predict who's going to get a good embryo, that has an accuracy of 0.84. The one that I was talking about using Medimo data to predict whether a patient is likely to return is much less accurate. So that has an accuracy of just over 0.6, so 0.64. Our initial aim with this machine learning and AI type of work was to use emotions to build into Medimo a algorithm that would alert us if the patient was showing signs that they were finding the IVF really stressful and were likely to drop out after that cycle of treatment. I think realistically, based on our evaluation so far, the predictive value of the emotional scores is not strong enough to make that possible at the moment. We're kind of exploring different ways that we could record emotional data. So could we ask patients to record short videos, or kind of have further to record more detailed, more granular information about how they're feeling during the cycle in any way. But at the moment, with their responses to questions, I think we've got a limited predictive power.
Yeah, there's a follow-up question from Carlo.
Yeah, it's something that we're exploring at the moment. I think we need to do the SHAP analysis to work out exactly what it's using to predict. And we were using kind of mean mood score right across the cycle, so kind of a temperature check of how the patient is feeling across the cycle. And you could see from the graphs that emotional responses vary significantly during the different phases of the cycle. So probably models that are drawing more, that can kind of get more information from the database that we have already, may increase predictive power, but that's kind of exploratory at the moment.
Are you now able to do on a to show statistically significant better outcomes with the app versus not
So
using the app?
that's what we're, so the problem is that we haven't had funding to do a randomized trial of app users or not, which is the only way that you could prove that. We
Right.
have done a time series analysis. So after we introduced the app, the rate of patients returning for more treatment cycles increased by more than 2, the odds ratio of before versus when the app was introduced to the cycle. So there's kind of suggestive evidence, but other things obviously have changed during that time. So you can't make a kind of, it's certainly because the app was introduced comment. But we're hopeful still that we'll get some funding in order to do a direct comparison. The problem is the app use is quite embedded within our centre already, so it may have to be a multi-centre study in order to recruit to that study. But yeah, great questions. It's interesting to get different points of view.
We would like to thank Dr. Isla again and our participants for having this session with us here in AeHIN.
Yeah, very welcome. Thank you. Thanks for the invitation.